Welcome everyone to today's HPL seminar. Today we'll be hearing from Emily Bishop. Emily Bishop is currently a postdoc with Dr. Janet Wronski. Dr. Bishop completed her bachelor's degree in mechanical engineering at Queen's University and her PhD in biomedical engineering here at the University of Calgary. Her PhD was advised by Dr. Janet Wronski, and the title of her dissertation was Dynamic Stability of the ACL Deficient Knee. Janet has held a variety of other positions, including a clinical trial coordinator at Zephyr Sleep Technologies, a sessional instructor at Mount Royal University, a coordinator of biomedical research at the University of Calgary, and a biomechanics consultant at Orphix Medical Technologies. Her research interests include strategies for managing knee osteoarthritis and understanding the effect of interventions and devices on biomechanics. She hopes one day to be a researcher in the medical device industry. In her free time, Emily enjoys downhill skiing, hiking, camping, and park outings with her little boy, Oliver. As a reminder, I'll first turn it over to Emily for her presentation, and then we will have a question and answer period to follow. Emily, you're welcome to start screen sharing when you're ready.
Perfect. Thank you for the intro, Emily. All right, everyone's seeing that okay?
Perfect.
All right, so thanks very much for the opportunity to present today. I'm excited to share this work and looking forward to the discussion afterwards. So today I will be talking about tri-compartment offloading, a biomechanical evaluation of the spring-loaded knee brace. And so this is work that's been done as part of my MyTax here at the University of Calgary, and the industry partner on the MyTax is Spring-Loaded Technology. They are a company out of Halifax, Nova Scotia. So just as an overview, I'll start by presenting the clinical problem, then move on to introducing the spring-loaded technology knee brace and talking about some previous research that's been done on the brace. Then I'll get into the biomechanical evaluation that we've done here at the university and wrap up with significance and next steps. So 1 in 3 adults between the ages of 18 and 64 have arthritis. And by the age of 85 in the United States, you have a 45% lifetime risk of developing knee osteoarthritis. So the prevalence of this disease is very high and it's continuing to rise. The knee is the most commonly affected joint, and degeneration of cartilage in the joint causes symptoms such as pain, inflammation, and stiffness, which all lead to a reduced quality of life for those suffering from knee osteoarthritis. So knee braces are a common conservative management tool to address knee OA symptoms and improve function. However, traditional offloader knee braces only offload one compartment of the knee. And so there's a lack of effective bracing solutions for the majority of knee osteoarthritis patients who have involvement of multiple compartments within the knee. So cyclical loading and unloading of the joint, for example, when we're walking or going up and down stairs, is critical for the maintenance of healthy cartilage. And we know that the normal distribution and the amount of loading in the knee changes with knee OA. Research has shown that increased loading is related to both the initiation and progression of knee osteoarthritis, and that excess loading induces symptoms of knee pain. So joint unloading aims to reduce and redistribute these loads to avoid further damage and potentially encourage healing within the joint. And so there are several ways that joint unloading can be accomplished: by weight reduction, activity modification, the use of walking aids, joint distraction, or knee braces. And that's what I'll be focusing on today. And so I just want to mention that research has shown, as far as unloading the joint goes, that a minimum of 10% weight loss provides a clinically meaningful benefit for patients with knee osteoarthritis, and more than a 20% equivalent weight loss is optimal and maximizes clinical benefits. So that's sort of a target amount for unloading the knee joint to see those benefits. So traditional knee osteoarthritis braces, like the one shown here, are typically called uni-compartment offloaders, and they function by mechanically realigning the joint. So they apply a force to the affected side of your knee to open up the joint space on the opposite side of the knee and redistribute the forces across a larger area within the joint. So these braces are cost-effective, they're minimally invasive, and they've been shown to reduce pain, improve function, and potentially even delay the progression of knee osteoarthritis for the right patients. And those patients are those with uni-compartment tibiofemoral knee osteoarthritis. However, the vast majority of patients are likely to have damage or osteoarthritis in 2 or all 3 compartments of their knee. So uni-compartment tibiofemoral OA accounts for only 3 to 20% of knee osteoarthritis cases. There are a few other potential limitations to these traditional uni-compartment offloader braces. So by the way that they function, by transferring load to the opposite compartment of the knee, that could potentially cause degradation or damage with long-term use. They're also designed primarily to unload the joint during walking and not necessarily during activities involving higher degrees of knee flexion. And we know that loading within the joint increases with knee flexion. So we see higher joint forces going through the joint during activities with higher knee flexion angles. So I just want to talk about sort of what's happening at the knee in the sagittal plane during a weight-bearing flexed position. So here we have an individual either rising or sitting down onto a chair. And so at the knee joint in the sagittal plane, we have this external knee flexion moment. So a moment that's tending to flex the knee, and that's caused by gravity and the center of mass. And in order to balance that moment, so we don't just fall to the floor, we need to generate an internal knee extension moment, which is provided primarily by the quadriceps. And so these two measures are important because we know that knee flexion moment contributes to both patellofemoral and tibiofemoral joint contact forces, and is also significantly affected by OA-related knee pain. And the quadriceps are also primary contributors to compressive forces in the tibiofemoral and patellofemoral compartments. And so because of this, knee flexion moment and quadriceps activity could provide key biomechanical targets for knee osteoarthritis interventions. So putting all of this together, including the benefits and the limitations of traditional braces for knee osteoarthritis, and the focus on unloading the joint in conservative management of knee osteoarthritis, formed the motivation for spring-loaded technology to develop a new type of knee brace. And this brace is referred to as a tri-compartment offloader, or a TCO brace. So unlike traditional braces, the spring-loaded TCO brace targets compressive forces caused by muscle forces in the joint. So the TCO brace uses powerful liquid spring technology to provide an assistive knee extension moment, essentially assisting the quadriceps to reduce compressive joint forces in all 3 compartments of the knee. And it works during weight-bearing knee flexion. So also important to note that the level of assistance provided by the brace can be adjusted, and in the current model, there's low and high power modes, so providing less or more amounts of assistance. So I'm just going to take you through a little bit of the design of the brace and then some previous research that's been done, and then we'll get into the work that we've done here to evaluate the brace. So we know from a couple slides before that a 20% reduction in body weight provides clinically meaningful improvements for knee osteoarthritis patients. And so this became the design goal for the spring-loaded technology knee brace. So these are just a few examples of other knee extension assist devices that exist on the market. You can see that some of them are quite bulky, and we also don't know whether they provide that desired unloading effect of sort of an equivalent of 20% reduction in body weight. So in their design, spring-loaded technology evaluated several existing traditional and liquid springs, but they all failed to meet the requirements for the TCO brace. So they developed a proprietary liquid spring to provide the required force output for the TCO brace. And the spring consists of 2 fluid-filled cylinders with pistons, and together they provide a force output of 500 pounds of force per 1 inch of deflection. So these are the springs here, and they're housed in the shell of the thigh shell on the outer side. So spring-loaded technology performed mechanical testing to determine the assistive moment provided by the TCO brace and compared it with a commercially available knee extension assist brace called the OA Rehabilitator. And that's the only other knee extension assist brace that's been published on in the literature. So they measured static force output at several brace flexion angles up to 90 degrees and found that at 90 degrees of brace flexion, the OA Rehabilitator provided a moment of 22 inch-pounds, where the TCO brace provided a moment of 181 inch-pounds. So quite a significantly more assistance provided by the TCO brace compared to the OA Rehabilitator. So next, they wanted to understand the potential of the brace to unload the knee joint. So they used a static analysis of moments about the knee center at 90 degrees of flexion, and they used a published biomechanical model shown here. So in this model, knee joint forces are directly proportional to one another and are all dependent on the magnitude of body weight. So what they did was calculated the assisted patellar tendon force shown here and found that essentially the assistance provided by the TCO brace effectively reduced body weight by 45 pounds. And this reduction in joint force would be seen in all compartments of the knee, so patellofemoral, tibiofemoral as well, because they're all a function of body weight. And then these assisted joint contact forces were calculated for both the TCO brace and the OA Rehabilitator brace, assuming an average osteoarthritis patient weighing 205 pounds. What they saw was the OA Rehabilitator would provide a 2.7% body weight reduction, while the TCO brace would provide a 22% effective body weight reduction. So from these results, the design goal of the TCO brace was met in that it was providing more than a 20% effective body weight reduction. And these results were published in 2020 in the Journal of Biomechanical Engineering. So I'm just going to play a quick video here just so that you can sort of visualize how the springs in the brace work.
Our powerful liquid springs embedded inside the brace absorb body weight.
So you can see as the brace flexes, the springs compress, and so sort of supporting body weight, but also storing potential energy.
When the knee is bent, by transferring weight away from the knee, spring-loaded braces can reduce the forces normally placed on your knee by up to 64%.
And then, so they compress as the brace flexes, and then as the brace extends or as someone rises up, it's giving back that potential energy and assisting the extension motion. And so Next Spring-Loaded Technology performed a retrospective study on a sample of spring-loaded technology customers who were using the brace and who had symptoms of knee osteoarthritis. And what they found was that users reported average total pain scores decreasing by 36.6 millimeters on a visual analog scale. So that's out of the scale of 100 after using the brace compared to before. 97.5% of patients had significant improvements in function. 70% reported increased physical activity levels. 60% reported a decrease in their use of other treatments for knee osteoarthritis. And of those who regularly used pain medications before using the brace, 65% were able to either reduce or eliminate their use of medications. So this was the first evidence from spring-loaded brace users showing that the brace was having a positive effect on knee pain, function, physical activity, and medication use. And this work was published in 2021. So this next piece of work was looking at modeling the joint contact forces, and it was a collaboration between researchers at the University of New Brunswick and the University of Guelph. So they used a biomechanical data set from 8 healthy participants doing a deep knee bend test. And the data consisted of 3D kinematics and ground reaction force data. And they used a sagittal plane knee model consisting of the tibia, femur, and patella, anterior and posterior cruciate ligaments, and the quadriceps, hamstring, and patellar tendons. And then the TCO brace, the effect of the assistance of the TCO brace was modeled by applying an external extension moment at the knee joint. So what they looked at was the joint contact forces without using the brace, and then with the simulated brace. So here I'm showing the contact forces in the tibiofemoral and patellofemoral compartments, as well as the quadriceps tendon force. And this is during the deep knee bend test. So you sort of see these peaks in contact forces at the deepest part of the squat. And the condition without the brace is shown in blue, and then the condition with the simulated brace is shown in green. So what they showed was a significant reduction in tibiofemoral contact force above 15 degrees of knee flexion, and a significant reduction in quadriceps tendon force and patellofemoral contact force above 45 degrees of knee flexion. And magnitude-wise, what they found was that at a 90-degree knee flexion angle, the TCO brace reduced tibiofemoral and patellofemoral joint contact forces by over 40%. And this work was published in 2021. So far, the work prior to what we've done at the University of Calgary showed that the brace provides an equivalent benefit of 45 pounds of weight loss at a 90-degree knee bend, provides over 40% reduction in joint contact forces in both patellofemoral and tibiofemoral compartments of the knee, and that 100% of users reported reduced knee pain since using the spring-loaded brace. So the overall research goal is to quantify the unloading effect of the TCO brace. And so the work done by McGibbon and others, published in 2021, was a critical first step in understanding the unloading effect of the brace, but there were a few limitations. And some of those are the biomechanical data used was from healthy individuals, not the target users who are patients with knee osteoarthritis. The brace was simulated and it was assumed to track the leg perfectly because we didn't have data with participants actually wearing the brace. And the kinematics and kinetics were therefore assumed to remain unchanged in the brace condition. And so for the work we've done at the University of Calgary, the goal or the question was, how does the spring-loaded TCO brace affect both biomechanics and joint loading in individuals with knee OA. So for the first time, directly measuring the effect of the brace in patients with knee osteoarthritis. And so we aim to determine three things. So first, what is the biomechanical effect? Second, what is the effect on joint loading? And third, what is the effect on knee pain? And so this work was performed at the Clinical Movement Assessment Lab over in the McCaig Institute under the supervision of Dr. Janet Ronsky. So for the study, we recruited patients with unilateral patellofemoral or multi-compartment knee osteoarthritis with KL grades 2 to 4. So the diagnosis and the severity of knee osteoarthritis was confirmed radiographically by orthopedic surgeons. Patients were required to have a BMI less than 35 because of the nature of the data collection. And they were excluded if they had corticosteroid injections within 3 months of the study, because we were also looking at measures of pain. So we ended up with a sample of 9 participants, 6 males and 3 females. They all had the same pattern of knee osteoarthritis, so combined medial tibiofemoral and patellofemoral OA. They had an average age of 61.4 years and an average BMI of 30.4. And so just to characterize the assistance provided by the brace, I mentioned previously that there's 2 power modes, so a low power and a high power. So in low power mode, and so here the graph is showing the assistive moment provided by the brace on the y-axis in Newton meters, and along the x-axis, the brace flexion angle. And so these curves are based on mechanical test data performed at spring-loaded technology with the brace. So in high power mode, the spring engages immediately, so starting at 0 degrees. So we get this linear increase in the moment provided by the brace as the brace flexion angle increases. And then in low power, indicated by green, the brace spring engages at 45 degrees of flexion. So from 45 degrees, then we have a linear increase in extension assistance. So for the data collection, participants performed 3 dynamic tasks: walking on a level surface, chair rise and lower, and stair ascent and descent. And they performed all of these tasks with 3 brace conditions, and the brace conditions were randomized. So they performed it with no brace or off. They performed it with the TCO brace worn in low power and the TCO brace worn in high power. And we collected 3D kinematics from the lower limbs as well as the brace, ground reaction force data from the braced leg, and EMG of the quadriceps and hamstrings from the braced leg. Following each dynamic task, we asked participants to rate their knee pain and the difficulty performing the task on a visual analog scale. So to look at biomechanical effect, our primary outcome measures were the knee joint flexion moment. And so this was calculated using an inverse dynamics approach with visual 3D, and as well as quadriceps muscle activity. And we took a wavelet analysis approach for this. To look at joint loading, we assessed tibiofemoral and patellofemoral joint contact forces using a sagittal plane knee model. And to assess knee pain, we used the visual analog scale. So starting with the knee flexion moment, again, here I'm showing the assistive moment provided by the brace. And then here on the right-hand side, this is a plot of knee flexion moment during the chair rise and lower. So we sort of see these 2 peaks as the participant rises from the chair and then as the participant sits back down into the chair. So we have these 2 distinct peaks. The solid red line is the external knee flexion moment that we measured. So this is due to the flexion moment due to the ground reaction force and the kinematics of the movement, and it doesn't account for the brace moment. In the solid black line here is the assistive moment provided by the brace. So that's calculated based on the measured brace flexion angle, and this torque curve here. What we're really interested in is this dashed red line, which we're calling the net knee flexion moment. So this is the knee flexion moment that the knee experiences, taking into account the assistance provided by the brace. So these are the kinematic and kinetic results for the chair rise and lower. So the top graph here is showing knee flexion angle during the chair rise and lower. So you can see they start at a flexed knee position, they stand up and then sit back down. And going forward throughout the presentation, the three conditions are represented. So off is blue, the brace worn in low power is green, and the brace worn in high power is red. On the bottom graph here, we have the normalized knee flexion moment. So it's normalized to body weight and height and averaged across all participants. So we see this trend here of the highest net knee flexion moment being with the brace off, then lower with the brace in low, and lowest with the brace worn in high. So we're seeing that the extension assistance provided by the TCO brace results in a reduced knee flexion moment. So diving in a little bit and looking at the contribution of the brace to the knee flexion moment. So showing the knee flexion moment in low power and in high power. We analyzed the peak knee flexion moment, so the first and the second peaks, and found significant differences at both peaks in both low power and high power mode. So in low power mode, the TCO is reducing the knee flexion moment by 8 to 13%, and in high power mode, it's reducing it by 17 to 27%. And it makes sense that we'd see a larger reduction in high power mode because the brace is providing a higher level of assistance. These are the kinematic and kinetic results during stair descent. So again, we've got the knee flexion angle here. And the portion of the task we looked at during stair descent was basically from the point where the leg of interest hit the force plate on the step of interest until the point where the foot lifted off. So we sort of have this weight acceptance or loading phase, and then this push-off phase as they step onto the next step. So again, we see two distinct peaks in the knee flexion moment here. And the average curves for the off condition and the low power condition are quite similar, but we do see with the brace worn in high power in red here that it reduces the knee flexion moment compared to the off condition. Again, looking individually at low power mode and high power mode, we didn't see any significant reductions in knee flexion moment with the brace worn in low during stair descent. However, in high power mode, we saw significant reductions in both peaks, and specifically at the second peak during the push-off phase, we saw a 15% reduction in peak knee flexion moment. For the EMG analysis, we used a wavelet analysis approach. So here I'm just showing a representative raw EMG signal from an individual participant during the chair rise and lower task. So we see this burst of activity as the participant rises to standing, and then a second burst as they lower to seated. Next, we have the wavelet plot. And what we did was we summed the intensity signals across all frequencies to end up with total muscle intensity over time. So that's this plot here. And then for comparison purposes, we computed total muscle power. So summing this total muscle intensity over time to end up with a measure of muscle power. And that's how we compared across bracing conditions. And also important to note that we did normalize the EMG signal. So we did maximum voluntary contraction tests on the biodex and normalized the signals to the maximum MVC signals. So here I'm showing normalized muscle power on the y-axis. So we have the results for the vastus medialis during the chair rise, chair lower, and stair descent on the left-hand side of the plot. And then on the right-hand side of the plot is the results for the vastus lateralis for the same tasks. You see this sort of general trend of decreasing muscle power compared to off with the brace worn in both low and high. With the brace worn in high power, we saw a significant reduction in muscle power compared to off in the vastus medialis for all three tasks, and for the vastus lateralis during the chair rise and chair lower. However, this difference was not significant during stair descent. And then we also saw a significant decrease with the brace worn in low power for the vastus medialis during chair lower and stair descent. So magnitude-wise, with the TCO brace worn in high power, on average, we saw during the chair rise and lower, the vastus medialis was reduced by 53 to 67%. The vastus lateralis reduced by 34 to 39%. And during stair descent, we saw reductions in the VM and BL of 36 and 30% on average. So these results are exciting because it's the first time that the quadriceps activity or the changes in quadriceps activity have been measured in patients with NEO-A actually wearing the brace. And the results provide evidence supporting the previous modeling work, which showed a reduction in quadriceps forces. So to discuss the biomechanical effect, the results that I just showed show that the use of the TCO brace has an immediate biomechanical effect. So we saw reduced knee flexion moment and reduced quadriceps activity. We know that quadriceps contraction produces an internal knee extension moment to balance the external knee flexion moment. So if we have a lower net knee flexion moment, it makes sense that we would have lower quadriceps activity. These results are important because knee flexion moment and quadriceps contraction both contribute significantly to tibiofemoral and patellofemoral joint contact forces. So these results, these reductions in knee flexion moment and quadriceps muscle power are predicted to contribute to reduced joint contact forces. So next we wanted to look at the effect of the brace on joint contact forces. And in order to do this, we need to rely on musculoskeletal modeling to estimate the contact forces within the knee joint. So we used a sagittal plane knee model to resolve patellofemoral and tibiofemoral contact forces. This model had been previously validated against Grand Challenge dataset, and the model predictions were shown to be valid between 0 to 100 degrees of knee flexion. And so the brace in this instance is modeled as FB, the force here on the tibia, and it's the force produced by the TCO brace applied to the tibia, and it's a function of the brace flexion angle. And so this model resolves muscle tendon forces, cruciate ligament forces, and joint contact forces in the sagittal plane. So these are the results of the joint contact force analysis. So we have joint contact force normalized to body weight on the y-axis. And then this has only been done so far for the chair rise and lower. So we've got on the left-hand side of the graph, the tibiofemoral contact forces, and on the right-hand side, the patellofemoral. And these are analyzed separately for the rise and lower portions of the task. So what we see is with the TCO brace worn in high power mode, a significant reduction in both tibiofemoral and patellofemoral contact forces compared to not wearing the brace during both phases of the chair rise and lower. And we also saw a significant reduction with the brace worn in low power in both compartments during chair lower, but not during chair rise. So with the brace worn in high power, in chair rise, we saw reductions of 23% and 21% in the tibiofemoral and patellofemoral contact forces. And in chair lower, we saw reductions of 29 and 33% in the tibiofemoral and patellofemoral compartments. So those results showed that using the TCO brace significantly lowers tibiofemoral and patellofemoral joint contact forces. And these reduced joint contact forces are likely related to the reduced knee flexion moment and quadriceps activity that was observed. But these study results support multi-compartment joint unloading via extension assistance with the TCO brace. And finally, the results of knee pain. So participants reported their level of knee pain on a 100mm visual analog scale, 0 representing no pain, 100 representing the worst pain possible. And these results are presented for the chair rise and lower and stair descent. So what we see is significantly reduced pain levels of pain with the brace worn in both low and high power mode in both the chair rise and lower and stair descent. With the TCO brace worn in high power, we observed an average reduction in pain of 19mm during the chair task and 24mm during stair descent. So not only are these reductions statistically significant, they're also clinically significant. So the amount of change in pain is well above the minimal clinically important improvement, which is 10.8mm. So participants reported significant and clinically meaningful reductions in knee pain with TCO brace use during the chair rise and lower and stair descent. It's expected that these reductions in pain are related to reduced joint loading, because we know that there's a relationship there between the amount of load in the joint and pain. And so it tells us that the TCO brace is capable of providing a rapid beneficial effect on joint pain during weight-bearing knee flexion activities. So in summary, for the biomechanical effect, we observed reduced knee flexion moment and quadriceps activity. For joint loading, we observed reduced joint contact forces in both the tibiofemoral and patellofemoral compartments of the knee. For knee pain, we saw reduced patient-reported knee pain during these weight-bearing knee flexion activities. And these results together provide evidence supporting use of the TCO brace to reduce pain and joint contact forces in patients with multi-compartment knee osteoarthritis. So the next steps in this research, up until now, the unloading effect has only been analyzed in the sagittal plane, so just looking at patellofemoral and tibiofemoral contact forces. But what we really want to get to is understanding the effect in all 3 compartments of the knee. So we need to look at the effect of the brace on the distribution of medial and lateral tibiofemoral contact forces. And so to do that, we need highly accurate kinematic data to feed into a model. So we're currently collecting data from the dual fluoroscopy system to enable us to do this. We'd also like to look at the biomechanical effect of the TCO brace during other activities of daily living. So we have walking data that we're currently analyzing. And then, the biomechanical data that I presented was short-term work. Participants were given 48 hours to become accustomed to the brace before we did data collection. So we want to understand the biomechanical and clinical effects of long-term brace use and whether there's adaptations over time, and specifically looking at how the brace affects pain, function, quality of life, and also how the brace affects lower limb strength, because we know that wearing the brace causes changes in muscle activity. Lastly, something interesting we could look at as well is determining the optimal level of extension assistance for different populations and different activities for future brace designs that have more adjustable levels of brace assistance. This is just to show the current study that we're doing in the dual fluoroscopy system. So a very similar study design, but just the kinematics will be based on bone movement from the dual fluoroscopy images. In addition to the biomechanical work that we're doing, we're also currently running a pilot clinical trial and doing a prospective user outcomes study in collaboration with spring-loaded technology. And on the product development side of things, there's work being done on adjustable assistance and improved brace fit. So I'd like to thank everyone for their attention today, and also my supervisor, Dr. Janet Ronsky, as well as the spring-loaded technology team, all of my lab members, especially Greg, who helped quite a bit with data collection and data analysis. The team over at South Health Campus, who were instrumental in helping to recruit the patients for this study. Dr. Marcia Clark and Dr. Eldridge Batuyang were the orthopedic surgeons helping to recruit. Dr. Chris McGibbon is our collaborator who helped with the joint contact force analysis, as well as the study participants for their time and participation. And with that, we can open up the floor for discussion.
Thank you, Emily. At this time, I kindly ask the audience members that if you're comfortable to please turn on your Zoom camera to allow for better discussion. To ask your question, you can use the raise hand feature or type your question in the chat box and I'll read it aloud. Arash, please go ahead.
Hi, thank you for great presentation. I just had a question about the force distribution. So there is a decrease in knee moment that is produced by the muscle, and I'm just wondering the extra force that is produced by the brace, where is it distributed? Basically where the force go? Is it gonna redistribute force at some other parts of the body, for example, on the femur or on the tibia?
Yeah, so the way that the brace, oh, I'm not sharing screen. So the way that the brace works, so the extension moment is essentially happening about the hinge of the brace, right? Which is at the center of the knee, but then it gets transferred to the leg, sort of at the back of the tibia, the posterior tibia and the posterior thigh, right? So it's tending to extend the knee. That's how it's working. So the concept is kind of that, you know, by providing that extension, that help with extending the knee, that it's reducing the amount that the quadriceps has to do that same thing, or quadriceps and or other muscles as well. So I guess as far as like, so your question is kind of like, where is that, if it's reducing the forces in the knee, where are those forces going?
Yes.
So I think you could kind of think about it as like the springs and the brace are kind of absorbing, like helping to absorb. That's one way that we can think about it, is that the brace springs are helping to absorb sort of some of the body weight almost, right? We know that if you lose weight, the contact forces in your knee are also reduced. So the brace is kind of helping to support that body weight. I don't know if is that making sense at all?
Kind of. And so eventually, if I'm getting it right, the force, the energy is being absorbed by the deformation of the brace. Is that how I should look at it?
Yeah, the energy is being absorbed by the liquid springs in the brace.
Okay.
right? So as you flex, those springs are compressing and storing that potential energy, and then it's given back to you as you extend. So the brace itself is quite rigid, but it's those springs embedded in the brace that are taking that potential energy.
Perfect. So if someone is, I'm actually asking this question because I know someone who has osteoarthritis in the knee and also osteoporosis. So in that case, I'm just asking if it is going to redistribute that force. Should I be worried about that? And someone is my mom. So
right. That's a good question, and something, yeah, I haven't thought about it that before. So I guess what you need to look at is whether a force being applied to the back of the tibia, if there's any concerns about that with someone who has potentially compromised bone strength, right?
Yes.
Yeah. No, great question.
Okay.
I don't have the expertise to answer that right now.
Thank you.
Osman, please go ahead.
Thanks. First question is, how does this brace works? How does it work when the swing phase of walking? In the termination of the stance phase, in order to get ground clearance, people need to bend their knee. And you said there's a spring between thigh and shank, right? But is it still connected while the person wants to bend their knee to initiate swing?
Yeah, great question. So that's kind of the concept behind having these two power modes. So the idea being that in low power, the spring's not engaging until like 45 degrees of knee flexion. With the hope that, during walking and in that swing phase, you're not gonna be walking with a stiff leg. But then for higher flexion activities, you could adjust it then up to high power mode, where you're not going to need that clearance, or sort of in activities where you're keeping contact with the ground.
So this means, I'm trying to remember the knee flexion angles while swing, and it should be up to 60 degrees, I guess, if I'm not wrong, for normal walking speeds. So even with the low power mode, if the patient, that being said, these patients are walking very slowly and maybe their swing like angle, their knee angle is lower than healthy people, but the spring is not completely disengaged from the leg, right, within swing, which means they need to put some more effort to bend their knee to swing their leg. And this might, in long term, would you expect this is not going to be very beneficial for people, or this might lead like hitchhiking, like hip hiking, which is moving the hip without bending the knee? This is one of the adaptations that these knee brace users have in long term. Would you expect these negative effects with this current design? I would expect there is a clutch which engages the spring within the stance phase and disengages it within the swing phase, which is called stance control knee ankle foot orthosis. There's a concept. Have you ever heard of it? Stance control knee orthosis?
I mean, so that's something that we have the data to look at. So we did collect data with people wearing the brace in low power mode during walking. So certainly we can look at, between not wearing a brace and wearing the brace, do we see just kinematic differences? Like, is it affecting the way that they're walking? Anecdotally, we didn't have any reports of this feels funny or my foot's not clearing the ground or anything like that. But it definitely warrants investigation, because I mean, walking is what we do to get anywhere. So if someone's wearing a brace, it's important that it doesn't interfere with walking.
Okay. I have one more question related to what I said. Did you look at center of mass work and other joint work while this chair rise and chair fall experiment? means when they wear the brace, did the mechanical work on center of mass, did it go lower compared to not wearing the brace? Because we saw knee moment and contact forces, but it doesn't mean the center of mass whole body movement is positively affected from wearing the brace.
We didn't specifically look at those measures that you're talking about. So you're saying center of mass.
The work done by the ground reaction forces on center of mass while wearing the brace or not wearing the brace. So center of mass is going up and down, right? Chair experiment.
Yeah.
When it goes up, muscles are active. They are the limbs are active. They are moving. They are doing mechanical work. What's the total mechanical work of the limbs and also the mechanical work of center of mass, which can be calculated? Does it go the whole body movement, or we can call it whole body movement, other than just focusing on the knee? The whole body movement, whole body mechanical work is going up or down when we sum the joint forces and look at the center of mass work while wearing the brace or not?
Yeah, great question. We haven't looked at that. It'd be great to look at. Thank you. Do you have any predictions of what we'd see based on what I showed, or?
I mean, knee moment goes down, so it's cool. So knee work should go down.
But then you're wondering if anything else is changing.
If nothing is changing, then we should expect total mechanical work on center of mass should go down. But it's a multi-body system, so it's a little difficult to say without seeing the data, right?
Yeah, no, that's definitely great to look at. And we liked, so the chair rise and lower, we chose to do that instead of like a squat, for example. We really wanted to have a really controlled movement, so that they were going down to the same level every time. So yeah, I don't know what we'd see in that, but certainly stair descent, that would be a great thing to look at, because we saw a lot of different strategies in stair descent and even stair ascent. So I think there's a lot of looking at things like trunk lean, and there's other things going on there, not just at the knee, so that looking at mechanical work could be a way to look at that too. So thanks.
I have a question, Emily. Towards the start of your talk, you mentioned that 20% reduction in body weight led to favorable knee outcomes. Is that correct? So what is that equivalent in reduction in knee loading?
Yeah, so I mean, yeah, it depends. So for example, if we look at that 90-degree just static analysis of the knee, for example, the force in the patellofemoral compartment is 5 times body weight, right? So if you have a 20% reduction in overall body mass, then you'd have 5, like, you'd multiply that by 5 kind of thing. Are you wanting like magnitudes, or?
I'm just curious then if some of the outcomes with the knee brace were similar to that,
right,
equivalent reduction.
Yes, and actually, yeah, that is something that I would like to do, and it's not something. So we'd essentially need to we'd need to run the model again. Yeah, I'm trying to figure out how to do that exactly, to say, like, for each participant, we have the reduction in contact force, but what does that equate to for that individual as far as an effective body weight reduction? Yeah.
Because you did all your modeling in a no brace condition as well, is that correct?
Yeah.
I'm wondering if you could just run the same thing but change your body mass to 80%.
Exactly.
Yeah.
Exactly. Yeah.
Walter, please go ahead.
Yeah. Thanks, Emily, for a very, very clear talk. That was very nice. I enjoyed that. I wanted to come back to the 20% reduction in body weight because I'm just conceptually curious about where that number comes from. And the reason why I'm asking the question is that, you know, we do this animal work where we feed these animals a high-fat sucrose diet, and they get bigger, and then they feed them something else, or we have them exercise, and then they get lower body weight. And when we do certain analyses, it seems at least in these animals, body weight doesn't really matter, but the metabolic difference with increasing body fat and decreasing body fat matters enormously. And I wonder, when you have somebody who loses 20% body fat or body weight, which then I assume is mostly body fat, what metabolic changes do you induce? And is it really the loss of weight that actually makes an effect? Or is it the complete change in metabolism that these people have?
Mm-hmm. Yeah, great question. So I mean, the study that we're referencing, is I can't remember what the intervention was, like whether it was a diet intervention but yeah, essentially, they had a group that, you know, didn't change weight, and then they had groups that lost weight, and we're looking at you know, patient reported outcomes of pain and function, and just saw that, you know, within the group that lost weight, those who lost at least 10% had benefits, and 20% had better benefits.
Mm-hmm.
I also don't know, like I can't recall off the top of my head sort of what the time frame was in that, and I don't know if you can comment on, you know, looking at just reductions in mass versus changes in metabolism and body composition, what sort of the timeline is on those. You know, like if it's a couple of months and we see improvements in patient outcomes with weight loss, is that purely due to changed mechanics in the joint because of less weight, or could we see those differences due to metabolic changes?
Yeah. I mean, I don't have the answer. In the animals, the suggestion seems to be that in the big animals, we have all these inflammatory markers. We have LPS leaking through the intestinal walls. So we have this we have insulin resistance that's completely depressed. So we have all these really, really bad things happen in these fat animals. And when they lose the weight through exercise or through another diet, then that all goes away. And so my hunch would actually be that it's not so much the body weight, it's really more the metabolic changes. But, you know, I really don't know. The other thing that I wanted to ask is, you talked very little about walking.
Mm-hmm.
You talked about stair rise and coming down and sitting up and down. And why so little data on walking, which presumably would be what these people mostly do?
Mm-hmm. Yeah, I mean, yeah, so we have the walking data. We started out looking at the chair rise and lower because we wanted to look at an activity that, you know, sort of uses the full range of the brace and is an activity that's, you know, that's what the brace is designed for, is for these weight-bearing flexion activities. During walking, it's probably just more so providing stability rather than any sort of unloading effect.
Mm-hmm.
So we were really just trying to evaluate that unloading effect. So that's why we focused on the chair rise and lower, which is also, you know, a very functional task. Stair descent is, you know, reportedly one of the most difficult and painful activities for patients with knee osteoarthritis. So that was our motivation there. But yes, there's obviously a clear need to look at that walking data, and specifically just, you know, is the brace having any negative kinematic effects on the way that they're walking? Because we don't want there to be any potentially harmful adaptations to the way that they're walking. And certainly, yeah, they need to walk to get to where they're going. So
the other question that I had is actually goes to chair rising and chair lowering, because I'm looking at this from a muscle mechanics point of view, and the one is a concentric contraction for the quadriceps, and the other one is an eccentric. And every once in a while, I go hiking with people in the mountains that have a little bit knee problems and maybe a little bit osteoarthritis, and walking uphill, like concentric seems to be much less of a problem than going down the hill where they have eccentric contraction. I was wondering if you saw a difference in the pain and other measures potentially when people stood up, from a chair and did this concentric contraction, or when they sat down and did an eccentric contraction. Did you try to distinguish between the two, or?
So chair rise and lower, from the pain perspective, we didn't differentiate between that. They did it as a fluid movement, and when we collected pain data, it was for that whole movement. But we did collect pain data separately for stair ascent and stair descent. So we can differentiate there, sort of what the effect of pain was in those two activities. I don't have that data handy, but I can certainly follow up with you if you're interested.
Yeah, no, that would be interesting. And maybe one very quick last question. For knee joint osteoarthritis, one of the implicating factors or risk factors seems to be quadriceps weakness. And so here you have a device that essentially unloads the muscles and produces less EMG, and therefore presumably requires less force, and therefore might potentially contribute to more atrophy of the quadriceps muscles. But that's in itself considered a risk factor for knee OA. Have you ever considered that might actually be counterproductive?
Yeah, for sure. And it's a concern that we hear from clinicians often too. And so it's not something that we can answer yet, but it's something that we're currently evaluating. So what we sort of think is that, if for a patient the brace is able to effectively reduce pain, that the hope is that they would then be able to do more activity in general than they would without the brace. And we have seen that in that retrospective survey of brace users, is that it was, I think 70% of people who got the brace had increased levels of physical activity afterwards. So the hope is that just by doing more, that potentially we might see positive changes in strength over time. Obviously, that's something that we need to evaluate. So we're doing a pilot clinical trial now. It's a 3-month study, and we evaluate their lower limb strength at baseline, and then we'll evaluate it again after 3 months to see if that changes at all. And that'll be the first study sort of looking at that strength aspect and that concern that we do hear often.
I think that would be very powerful if you could show that with the brace use, they actually do more activity and therefore, stay the same or might even get stronger. I think that would be very powerful if you could show that. Thanks a lot.
And the idea too is that, with the adjustable level of assistance potentially over time, and, I think the brace has implications for rehab too after an injury. You can, over time, as you strengthen, you can dial back that assistance as you need it. So
yeah, very good. Thank you.
Brent, go ahead.
Emily, I like your answer to Walter's last question. Just set that one on repeat, because whenever I see somebody present on on assistive technologies, that question always comes up. There's a lot of unloading haters out there. And I like the idea that you guys are going to do that study to see what happens to the changes in the muscle strength. That would be really interesting to see. But it would be really neat if because there's less pain, they're able to do more, and so they don't have that atrophy effect. I did maybe just quickly a comment about the question also about where that 20% reduction comes to get clinical benefit. I'm assuming that's just in reference to Steve Messier's work, where they lose, he looks at losing body mass, and then they ask them about pain and pain management, and they calculate joint contact forces, and I think that's where that 20% mark comes from. And I think they show that, like, with every 1 Newton loss in body weight, you get 10 Newtons reduction in contact force or something like that. So I'm not necessarily sure that it hasn't much to do with the actual development of OA per se, and where then the metabolism part would actually be really important. But I don't know. Okay, so bear with me this question, because I'm an academic with no entrepreneurial interest whatsoever. But I feel like if I was this company, I would stop. Like, I wouldn't do any more research. I have shown that it reduces pain, improves scores of quality of life, and there's a mechanism to explain here. You can say that it decreases the knee joint moment and reduces muscle activation. I feel like that's a good enough story, right? Like, why, what do you, from a marketing perspective, why do you need to do more research with this device? You could start looking at different patients, obese patients, non-obese patients, and all of a sudden find out, we don't get the 45-pound load reduction when we go to this population. We only get 10 per. I mean, I see, like, from a scientific perspective, I see why the research is really important. From a company marketing perspective, I'd probably want to shut it down now and just say it's good.
Yeah, awesome point. So I think there's still, I guess to start off, and I think there's obviously a lot of brace companies out there. There's some really big ones. Some of them do research, some of them don't. The reason that initially spring-loaded technology was so interested and invested in doing this research was that because the way that the brace worked was so different, right? So yes, we're well on our way now to proving out that it unloads the joint, both compartments, and proving out that sort of hypothesis and mechanism of unloading, that it's, assisting the quadriceps. And so that's all data that they can now use to help explain how the brace works, and to be able to make those claims about what the brace does, right? Yeah. And there's still a lot of education that needs to happen. And so definitely that strength concern is something that comes up a lot. And so that's what the pilot clinical trial and the full clinical trial is hopefully going to address. Yeah, I mean, on the biomechanics side of things, yeah, we're kind of at the point of publishing a lot of this, but we are undertaking this dual fluoroscopy study, and because it's marketed as a tri-compartment offloader knee brace, we haven't actually really shown that it does unload all three, right? We say, yeah, in the sagittal plane, it's tibiofemoral and patellofemoral. We can kind of assume, it's unloading both tibiofemoral, but we haven't actually shown that. So that's what that's sort of the whole goal with this DF study is, like, can we actually get good enough biomechanics data to look at loading in all three compartments of the knee? And that will be like the evidence to say this, here's proof that it unloads all three.
Yeah. Yeah. Okay. That makes sense, especially the if clinicians are concerned that it could weaken the muscles and actually be worse for the knee. I guess if you can show them that that's not the case and you get the clinicians on board, then you could potentially better market this kind of thing.
Yeah, the other benefit of the clinical trial is, you know, the data that I reported on, you know, patients reporting decreased pain and function, they were very, very promising, but obviously there's a huge bias there because it's customers of spring-loaded technology. So these are people who have actively sought out bracing as a solution, have invested their money to buy a brace. They're hoping that it works for them, right? So in the RCT, we're recruiting a specific set of patients who have not actively sought out bracing. So it'll be interesting to compare the results of the RCT to what they've shown with their customer base. But yeah, who knows? Maybe it won't be in favor for them.
You know, you can distribute that joint contact force between the medial and the lateral compartments. You just make some assumptions and you look at the abduction. You can distribute it according to the abduction-adduction moment at the knee.
Yeah, we did some work. So in the DF lab, we do combined motion capture and dual fluoroscopy at the same time. And Greg put in an abstract, I think, to NACOB, that ab adduction, that was there was quite a big difference between the motion capture based data and the DF data. So I don't trust the motion capture data to look at that frontal plane distribution.
That's really interesting. Is it that the frontal plane moment is inaccurate, or is it that the assumption of the load distribution between medial lateral compartments being dependent only on that frontal plane moment or distributed according to that moment? Is it that assumption, or is it that the moment itself is incorrect?
Like we didn't take that analysis yet to contact forces. It was just looking at sort of the kinematics and the kinetics, the difference between DF based and motion analysis based.
Okay, so it's the moment. It's the moment.
Yeah.
Or the kinematics. Or
yes. Yeah.
All right. Thanks.
Walter, go ahead.
So, you know, since Brent brought it up, you know, the loading versus unloading haters and so, the one thing we know from animal models and also from humans that had knee joints braced or other joints braced for 4 or 6 weeks or complete unloading studies in animals, we know that complete unloading is really bad for the joint and very, very bad for the cartilage. But obviously you don't do that, you're partial unloading. But the other thing is that, you know, there's people in this world like the upcoming Cy Frank Memorial Lecturer, Eva Roos, who got incredibly famous and has, you know, tens of thousands of citations on her Google Scholar account for work showing that when you take a mild to moderate osteoarthritis sufferer and you have them undergo this strength training and GLAD type of program that's now also introduced in Alberta and I think in other provinces of Canada, which clearly loads your joint much, much more than when you just walk around. So you do a clear overloading. That's actually seems to be tremendously beneficial. So there would be people out there coming from a kinesiology, physiotherapy background that would argue we want to load these joints, we want to have high pressures on there, and we actually do that every day for 30 minutes or an hour or so. So how do you reconcile that with the unloading device?
Yeah, I mean, I guess just what's coming to mind is, you know, if we're sort of targeting patients with moderate to severe knee osteoarthritis who, you know, are their ability to exercise and to just to get around is affected so much by their pain that we're hoping to improve that pain by this unloading of the joint to allow them to exercise and do more activity.
So would you argue that maybe the loading scenario, the GLAD program, might be better for another population, more the mild to moderate, while yours might be better for the moderate to severe type of a patient?
I mean, I would hope that potentially, you know, if there's patients who experience a lot of pain in their joint, so much so that they're, you know, they wouldn't be able to do something like the GLAD program. Potentially, if they find that this unloader brace is something that helps them, maybe they can use the unloader brace to do the GLAD program. I don't think it's totally different populations. And I mean, you know, we're unloading the joint by, let's pull this up here, you know, 20-30%. So the idea is that it's a tool to reduce pain and enable activity.
Yeah, and I think that's a good point. I think at the end of the day, probably a patient doesn't really worry too much about how much do I load my joint or what does he do to the cartilage. I guess at the end of the day, they worry, how much pain do I have? You know, can I sleep? You know, because I'm pain-free, and can I do certain, you know, can I go up and down the stairs and be pain-free? You know, I guess pain is probably the primary thing, and I think maybe sometimes we forget that.
Mm-hmm. Yeah, it was in just like a little story. We had someone in earlier this week to do the DF study, and so they have to do a series of squats since they do it without the brace and then with the brace on in different levels of assistance. And so they probably do, like, I don't know, maybe 30 squats throughout the duration of the data collection, and they wear the brace on their bad knee. And the next day she emailed me and just said, well, the brace must have done something because it's my good knee that hurts today. That's just one story, but I just thought it was an interesting one. So I, you know.
Yeah. Thank you.
Any final questions from the audience? Great. With that, please join me in thanking Emily for her presentation, and thank you to all the audience members for their questions. I hope to see everyone again next week for the HPL seminar. We'll be hearing from Leila Aliza De Savari from TU Delft, and she'll be presenting on the mystery of balance control in older adults. Thank you again, Emily.
To both Emily's. Thank you both. Thanks everybody for coming. Have a good afternoon.
Thanks, Emily.
Thank you.